This is Dr. Monica Mahajan, Director Internal Medicine at Max Healthcare, New Delhi. As per the WHO, nearly 63% of the total deaths in India are not due to communicable, but rather due to non-communicable diseases. That's a huge number. And out of these 63%, 27% are attributed to cardiovascular disease. And this affects 45% of people in the age group of 40 to 69 years. So a big number, and mainly involving the people in the productive age group or the income generating age group of the country. Raised blood pressure is amongst the most important risk factors for heart disease. And moreover, it remains poorly controlled due to both lack of awareness about hypertension, lack of appropriate care through primary care, and then there is also the physician inertia and a poor follow-up from the patient side. So the inertia and the poor compliance both are responsible for a large percentage of the population being uncontrolled. In India, as per the WHO, the prevalence has gone up over the last 30 years, and almost 38% of men and 32% of women, from 29% to 28% in the last 3 decades, is the numbers that we're looking up. So despite that, nearly half of the people, or 51% of men and 41% of women respectively, with hypertension were totally unaware of their condition. Additionally, another 62% of the men and 53% of the women living with hypertension did not get treatment. So it's not just the challenge of unawareness, but it is also in terms of the lack of appropriate treatment and medication being initiated in these patients. And medication was used to control blood pressure in less than 1 in 5 men and 1 in 4 women, which is a bad number in hypertension worldwide. The International Society for Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines, and the inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings like our country, the optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimum standards of care that we need to follow in order to care for the people living with hypertension. Again, the AHA and the ACC have released a scientific statement in 2021, offering new guidance for management of stage 1 hypertension amongst patients with low risks of ASCVD. Amongst the low-risk adults, or the no ASCVD or 10-year CVD risk less than 10%, which is the low-risk category with stage 1 hypertension, wherein the stage 1 would be defined as a blood pressure of systolic 130 to 139 and a diastolic of 80 to 89 millimeters of mercury. The management starts with non-pharmacological therapy. So it's very important that you're addressing the salt intake and the exercise-related aspects of the non-pharmacological therapy for your patients. If the blood pressure still remains uncontrolled at 3 to 6 months of initiating this non-pharmacological therapy, it is time that you start the pharmacological management of these patients. Again, ARDS is a potentially fatal condition causing lung damage in COVID-19. And it has been found in a recent study that in the Journal of American College of Cardiology, metoprolol could reduce lung inflammation and improve respiratory function in patients with COVID-19 related ARDS. So this is a drug where we are finding a use in post-COVID related ARDS patients also who are on metoprolol have an additional benefit of reducing the inflammation in the lungs. Another aspect is that lowering the systolic blood pressure targets down to 110 to less than 130 millimeters range substantially reduces the CV adverse events in the STEP randomized trial, affirming the findings of the SPRINT findings in the older Chinese population. So amongst the 8,500 patients between the ages of 60 and 80 in China, the intensive target trimmed 26% off the composite CV risk. Findings from new second major trial supporting a lower target could unite the guidelines, which even amongst US professional societies ranges from a threshold of 130 to 150. So this is as per a latest article in the NEJM in 2021 that we are talking of a cumulative aspect of the guidelines in terms of lowering the systolic blood pressure to a target of around 130 or less. With regards to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure monitoring, we know that at night time, the blood pressure needs to have a nocturnal dipping. The 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on an office BP measurement, but also insists on an out of office measurement, such as ambulatory BP monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risks of mortality and a composite of CV outcomes. So when you're diagnosing hypertension and you're treating hypertension, it's not just the readings that you take in your own office, but it is important for your patients to get a home BP monitoring as well as an ambulatory BP to get a more clear picture as to what the risks and how relevant the information is. For every 20/10 millimeters increment of blood pressure measured at night, the risk of mortality increased by 23%. And the risk of cardiovascular events by 36%. So it's not important just to measure and control the blood pressure in the daytime, but the nocturnal readings are to be equally well controlled in terms of reducing the CV events happening in the nighttime. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. And here in the 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering a non-adherence and a non-compliance issue, it is important that combination treatments are particularly highlighted so that the patients are more compliant with the medication that is recommended for them. And the society says that an initial dual fixed dose combination of an ACE inhibitor or ARB with a CCB or a diuretic may be a good combination to start with. Since early July 2018, products containing valsartan have been recalled worldwide. And the reason for this was the detection of a known carcinogen known as NDMA. This can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. In almost 1 lakh patients who had received NDMA contaminated valsartan from Zhejiang, Huai, the manufacturer site for the highest level of contaminants which were found in this particular drug, every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients out of this 1 lakh that we are talking of. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patient population if they have taken the highest daily doses over 4 years. So the valsartan recall, accompanied by a significant increase in the rate of emergency department visits, highlights the fact that when we're looking at prescribing a salt, we also need to look at whether there is any carcinogen or a contaminant in the salt while we are prescribing the drug to the patient. We also need to do a background check as to who the manufacturer is and what the quality standards are. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this particular trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. So what the authors of HYGEA were trying to figure out was that if the patients take the blood pressure medication at night rather than taking the blood pressure medication during the day, does that impact any of the factors as far as the overall blood pressure control was concerned? This large study included almost 19,000 hypertensive patients and an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcomes, and an ambulatory BP measurement was performed for 48 hours to collect data on how blood pressure differed during sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. But again, we need to take the HYGEA study with a pinch of salt because we have more studies which are now coming on to say that whether chronotherapy actually makes an impact on the overall blood pressure control or not. So in the next 2 years, we have more data which will be coming out regarding the timing of the blood pressure medication. But needless to say, any medication that works for 24 hours has a smooth control curve as far as blood pressure is concerned. You can time it whether in the morning or whether at night, we need to have more substantial data regarding the timing of these drugs. But any drug which is long acting will work fine, whether you give it in the morning or whether you give it at night. So thank you so much for your patient listening.